Welcome to our resident panel discussion. This afternoon, what we want to do is ensure that we also get an idea of what the residents' perspective is for the residency phase of our program. And we've invited 4 guest speakers from the local area to be a part of our panel. So starting from my right, your left, our first panelist is Major Jess Christensen. He's an administrative resident at the University of Texas Health Science Center. Our second panelist is Lieutenant Commander James Ketzler. He's currently serving as an administrative resident at Northeast Baptist Hospital. Our third panelist is Captain Bonnie Short. She's an administrative resident at Brooke Army Medical Center. And our fourth panelist is Captain Eileen White, who is also at Brooke Army Medical Center. Why don't we begin by having each one of the residents talk a little bit about their background, and then we'll move on into questions. So, Jess, if you could start.
Well, good afternoon, everyone. I'm not sure if the mic's. My name is Major Jess Christensen. I was assigned to the University of Texas Health Science Center over the last year in the primary care department. A little bit about my background, and I'll kind of make it to my residency background, is that this year I completed over 45 rotations throughout my academic residency to areas not only in UT Medicine but around San Antonio. I also attended ACHE Congress. I got an opportunity to travel to Mayo Clinic and a rural health center in Mitchell, South Dakota. This has been an outstanding year for me. I've learned a tremendous amount to apply knowledge that we learned from the didactic here and be able to learn more about healthcare. So I'm excited to be here and look forward to answering your questions.
Okay.
Hello, everyone. My name is Lieutenant Commander James Ketzler, and I'm actually a San Antonio native, so making the decision to come to the Army Baylor program was a no-brainer for me. I got to come home for 2 years. I've been out at the Baptist Health System, working at Northeast Baptist Hospital, and it's been, like Jess said, it's just been a really great year of reflection and growth and application of the different tools that we've learned throughout the didactic year. Well, I'm sure we're going to speak more about our individual preceptors, and we'll give you a perspective on that. Myself, I am currently in the Navy active duty, of course. I'm a registered nurse, board certified in medical surgical nursing, and happy to be here, proud to serve.
All right, good afternoon. Captain Bonnie Short. I'm at BAMC, as Colonel Peacock mentioned. We've had a great year. There's been 3 of us at BAMC, myself, Captain White, and then we have a civilian who's been a resident with us, Doug Faber. It's been a great experience having the 3 of us there. We've been able to complement each other and just made our experience greater. Prior to this, I was in human resources in Korea, and I actually have had an opportunity to be a speechwriter for the United Nations Command, USFK commander in Korea. So that was a very unique experience for somebody who's an MSc, and has nothing to do with hospital administration. But I had a great I was able to go to be with a 1-to-1 cash, and I had a great 70 Alpha hospital administrator boss there, Colonel Stephen Hankins, and he really encouraged me to do the Army Baylor program, and I'm very excited that I have. While I was here at BAMC, of course, we did all the rotations through BAMC, but I was also able to go to Mayo Clinic Jacksonville. I went to Washington, D.C., where I was able to go to Hopkins, to the DHA, to Belvoir, which that new hospital is really amazing if anybody hasn't ever been there before. And their whole incorporation of evidence-based design, that was I was really glad I was able to see that. Plus, I got to go to Walter Reed and do a lot of the rotations here with Major Ketzler and Christensen. Sorry. Lieutenant Commander Ketzler. But other than that, I'll let Captain White go ahead and speak.
Hi, ladies and gentlemen. Captain Eileen White, also at BAMC. She said a lot about what our experiences were at BAMC. For me, I came from First Cav at Fort Hood, and then went to the Fort Knox Hospital, and really fell in love with administration as a DenTech XO company commander. Being able to help dentists and let them be in the chair and seeing how rewarding that was, of them coming to me and actually asking for help so they can get back to what they're supposed to do. And that's when I fell in love with being an administrator and got an opportunity to come to Baylor. So I'm excited to talk to you about this past year. I really had a good time. Thank you.
Well, one of the things that we've been talking about today is preparing for the residency year. So one of the things that we're interested in from a student perspective or a resident perspective, how did you prepare for that initial meeting with your preceptor? And how do you think you did with respect to that? Did you feel like you had all the tools readily available for you, or is there something that perhaps you wanted to do differently? Jess, would you like to begin?
Okay. So the initial meeting with the preceptor was one of the first things I kind of planned for once I got on the ground at my residency. I emailed them prior to, and it actually occurred on the first day I was there, and there were some key things that I wanted to inform you guys of that the resident should probably bring to that meeting. The first is their bear that they've been working on throughout the didactic year. That was really important for me to identify what competencies I needed to focus on throughout my residency and make sure my preceptor understands that. The second one is I actually brought my leader development plan, so that I learned I wrote in my leadership course, and that helped me identify the specific areas of leadership that I wanted to focus on. Public speaking, so my preceptor recommended, hey, why don't you do the Toastmasters program here in UTESCA. So something like that to kind of get the ball rolling on the competencies, that not only that the resident needs to improve upon, but also that they want to excel in. So they might be at a medium level competency on their bear, and they want to really be good at, process improvement or some competency. So, and then finally, the last thing is the residency manual. My preceptor was her first year, I believe, doing as a preceptor, so I had to kind of lay out the objectives, like when we have the teleconferences, when kind of the main suspense due dates are throughout the entire year. So it was a reminder for her. She had some training from Baylor, so she did know about them prior, but it was a good reminder to go over them. So those are the three key things from my perspective.
James, do you have anything you'd like to add?
Certainly. I guess the first thing I did to prepare for the meeting, that initial get-together with the preceptor, was we sent our resume or our CV to them to review ahead of time. I would highly suggest that if you have the time, please review that prior to the meeting. Because if you go in for a 30-minute or longer meeting with the preceptor and they haven't looked at that, you spend a lot of time talking about your background and experiences, which maybe would have been highlighted in the resume. So I think that's a good idea. If you can, please make the time to do that ahead of time. That being said, when I did meet with my preceptor on that actual meeting, we sat down and we did talk a little bit about ourselves, just to get to know each other, about my background. And it was important for me to let the preceptor know that I wasn't, not to belittle anyone, but I wasn't just going from maybe a bachelor degree program right out of high school and then right into a master's degree program with no work experience at all. It was important for me to know that they knew that I had some, over 10 years of nursing experience, that I'd worked in a hospital environment at four different military treatment facilities, and that my interest and perspective was to try to gain something about what civilian hospitals were all about. That was important to me when I met with that individual. The last thing was, as that meeting concluded, immediately the physician recruiter came in for the system that I was working for, and there was a conversation right away in front of the preceptor in front of me about potential providers that were coming into the facility. So I made it clear to my preceptor that all those conversations were going to be held in confidence. and that they could rely on me not to divulge any information or anything like that. And I felt that that made a nice rapport with that individual, and that throughout the course of the residency then, I think only twice I was asked to leave a meeting. So it kind of opened doors by setting the foundation, by doing that early on. And one other thing was that many of you, I think, come from an Army or military background, and it meant a lot to me for my preceptor to tell me that he was going to treat me as though I was his chief of staff. And that meant something to me. It meant, okay, so I can go to his meetings, I'm going to track his schedule, I have access to his schedule, things like that. And that was important because it basically was the keys to the kingdom. And after that, I think everybody kind of accepted throughout the hospital that, who I was working for and what my role was. It really did help clarify things just a little bit.
So for us, because we were here, we went to Baylor here at this location, and we were staying here at this location, we actually had the opportunity to meet with the residents that were, at BAMC at the time. So before we even started our residency and we knew we were going to BAMC, we set up a meeting and we had a luncheon. And so they kind of told us everything, what to expect. I'm going to set out the expectations for you. This is what we've gone through this year. We were going to have the same preceptor, so we knew what he would want from us. So I guess we had that kind of idea to start with. And I personally I went through and read through that residency manual 100 times through this entire year, but I certainly read through it to kind of get okay, this is what's expected of me through my academic year. And so I had those expectations. Colonel Swafford meets with us as a collective group as far as our residencies. He meets with us separately as an officer, but together as a Baylor resident group. And because he hadn't been this wasn't his first time as a preceptor, he very much knew exactly how he was going, what he wanted and what he expected from us. Before we even meet, it's we got an email said, hey, this is when you're meeting. These are the things I expect you to bring to the table. You need to know this. You need to have a tentative, plan for your rotation. And also the residents from the year before, actually one specifically, really was very helpful with us to try to set that stage. Hey, here's the template. This is what I did, so that we could use that to kind of know where we need to go from there. And then between the guidance from Colonel Swafford and from the resident last year, we were able to have a great first preceptor meeting. And I think I felt, as prepared as you can be, because it's kind of an ambiguous time. You're I don't even know really what the expectations are. And I think I felt that way through a lot of the year, even though I knew, but I didn't know what I was doing sometimes. So that's all I have to add.
Eileen?
That was good. I agree with Bonnie. We won't belabor that anymore, so as she said it well.
Okay.
Oh, that's
Sir?
question that I have is, so I was going to present it back to you as what are your expectations of a preceptor in your initial meeting?
Okay. Bonnie, do you want to start as far as what your expectations are from the initial meeting?
Well, I think my expectation was for him to kind of give me some guidance. I think because I knew ahead of time, he's a Baylor grad, so he knows what it means and what the program's about. And I was hoping to have a lot of mentorship. He's the DCA of BAMC, which is the busiest, most productive MTF in the MHS. So I expected that he was going to give me mentorship and guidance, and that's really what I was hoping for. Even though I felt like I had an idea of what he wanted, I was expecting he was going to tell me exactly what he wanted, and he did. So
he also provided us with his OER support form and the commander's OER support form, and that's stratified through standards. So what not meeting expectations was, what meeting expectation was, and what above expectation was. He did it at that meeting, and then gave us a deadline for when our OER support form was due. And anything that he expected of us, he gave us that day. So he obviously is seasoned. He's done it a lot, but at that meeting, we knew exactly what was going to be expected of us on the OER. And that was actually leading to the competencies, which was another question. On there, our OER support form said you have to move up this many levels in your competency, and if you do 28 of the 35, then that's exceeds expectations, and that's going to be based on my observations. And right from the start, he said I don't expect any of you to be above a 5 or a 6 in anything. So really setting the stage of, I know you think that you're really a really good leader, but I'm a 7, or whatever. So if you're going to base off of me as an 8 or me as a 7, then how much lower than me do you think you are? Which is a challenge to sit there and try and go through the competencies based on, okay, if he is an 8, so what am I? 15 years before him.
And brilliant.
Yeah, so I think that was really good. He's very quantitative and wants to see it in numbers, and that helped us tremendously. He really laid it out what he wanted from us.
So you really set the tone.
He did. Yes, sir.
Yeah. I just have a few things to add too. I went to a civilian organization, so I'm familiar with the MHS and military TO&E units. But I had, going to an academic medical center and the organizational structure in a civilian age, I was not aware of that. So my preceptor actually kind of pulled the org structure out or drew it out for me right away, and also kind of explained, how the department works, who the key individuals, I could go to get assistance, that kind of had a military history background or a business background, then she also laid out like some of their strategic goals. She kind of offered, suggested some project opportunities. She talked about some things that the department is going to do in the future that kind of sparked some ideas for me for a potential project. So she talked about strengths and weaknesses of the organization, and I thought that was really helped me out to understand, the organization when I first got there. Just not having worked in a civilian medical facility before. So.
James, do you have anything else you'd like to add?
No, I did a lot of what Jess said here about working in the difference between the military and the civilian organizational structure it was important to highlight that early on and to get the organizational chart so that I knew that, for example, a director in the Navy was essentially a chief of something in the civilian world, and try to kind of put everything into perspective. So that was helpful early on.
Well, a central theme for today has been competency development. So what I wanted to ask of the panelists was, how did your preceptor tailor your residency experience in order to support your competency development? And can you provide an example, perhaps?
Okay. Start that one off, and I think with the initial meeting, I had a quick follow-up meeting about a week later, and I presented my residency plan to my preceptor at that time. So we're looking at 1 to 2 weeks into the residency. We sat down and we reviewed it together, and I explained and clarified a little bit, but made sure, and my preceptor was aware of what the competency-based program, and that there were these competencies that we had to meet. Based on that, we used the residency plan that we developed, which is pretty much formatted, and we're given a template to follow from our residency manual. So it is available there as a resource. But we put that together and reviewed it early on, and that made a big difference. Then, kind of as we progressed through the residency, I really didn't have any hiccups until I think about the third quarter. We sat down to review my bear, what my progress was, and what we got out of that was I was missing medical bylaws. That was a competency I just hadn't really delved into yet, and I was finding it hard to who should I talk to? Where do I go? It just hasn't surfaced like a lot of other competencies did in my other projects. So in the end, he actually picked up the phone and called the chief medical officer for the system and said, "Hey, I have a resident over here who would like to know a little bit more about medical bylaws. I see you have a meeting coming up soon. How about you have a shadow and then have him tag along a little bit?" And so I was able to set that up. And so we used both the residency plan and the bear primarily, and doing quarterly reviews helped quite a bit.
I would say I would probably mirror a lot of what James said. I don't think that at the beginning, like when we worked out the residency plan, that either one of us, and I'm sure he probably was, but I don't think I was thinking about, I need to make sure I meet all of these competencies. However, he required us to give him a weekly report. So every week we had to turn in whatever we did, what we observed, and what maybe we had a recommendation was for that week. So that helped me along with the BEAR. I was able to fill out my quarterly reports, and then I would look and I would be putting in my competencies for that week. And so as I went along and as looking in that BEAR, and of course with Colonel Swafford's guidance, I would say, hey, I was looking down, I would add up what I'd seen, what I hadn't seen, and I'd be like, I'm really lacking here. And so then I would know and look at, because the rotation plan, like when you first put it out, it's very dynamic anyways. I mean, it changed so many times. You think you're going to go somewhere, that doesn't work out. You start off one path and you realize, well, that doesn't really make sense. I really need to do this now. And so because of that, it always changed. And so I think with it being so dynamic and looking at the competencies, that BEAR was really a good way to make sure I met all the competencies, and just keeping in mind it was dynamic.
I would just reiterate explaining to your resident from the beginning of how you're going to assess their competencies, because they're really the one at the end that initials next to it, and they're the one that are assessing that. So to really be clear of, this is what I'm looking for, this is the standard, and this is what I expect. He never said I expect you to meet or exceed all these competencies all at once. Should be a career-long journey. And so I want you to focus on, I really enjoy PCMH. Okay, well, what does that fit into here? And let's make sure we hit those and really tailor them to what our strengths are and maybe what we're interested in. So having us understand how he was going to assess us was really important.
I agree with everything they said. Just a few other things with the BEAR specifically. I think it's a great tool to, after the first quarter, you're going to see the projects. A lot of the projects that we did and some of my classmates did, a lot of them were process improvement. They involved a group and they had some leadership in them. So we saw those competencies starting to build up. So the hard ones for me, being a civilian organization, were leadership or military doctrine and some of the military competencies. Now, we did have it, so what my preceptor did, and this was really great, is she opened the door by communicating at the executive level across the organization for an opportunity to work with the Military Health Institute director. And that, I think, as a preceptor, that helped me out tremendously. Or just coordination at different organizations or different departments across the organization is very helpful. And then I think the BEAR is a great. I think I really started to see how the BEAR was working, after the first quarter, and how your competencies build up, and take the time with your residents to go through and sit down with them and go line by line over the competencies. I think that was something else I really appreciated my preceptor did, was to go down the line and look at everything, the key rotations or the key projects that I did. So that was about it.
Okay. Now, how did you all meet the required timelines? We've heard some techniques from the other panel members when the preceptors were up there as far as incorporating dates into the residency plan. Did any of you have a similar or different experience than that? And if so, if you had a different type of experience, how were you able to ensure that those timelines were met?
Yeah, it was just, I put mine into my plan, my rotation plan. I usually made sure that on there it said quarterly report. I put it in my calendar. Deadlines aren't that hard to meet if you know them. So I didn't really find it to be any kind of an issue. I don't know if anybody else had any experience.
Did anyone else have a different experience, or were you all using the same types of techniques?
I just recommend stay ahead. A lot of it is based on the preceptors there to facilitate along with the academic advisor, but a lot of it, my success this year, I think, for my personal, was based on my individual effort to go out there and experience the things I wanted to do and learn. So I just wanted to stay ahead. That's something I'd recommend to your residents when you get them. Just know the specific dates of when the reports are due, when your portfolio is due at the end of the year. As you get a month out, you should have a really good draft or the resident should, of what they expect to submit. And at least make sure they have they're working on a project or have projects, the right amount to complete for their portfolio. That's my recommendation.
So, Jess, you touched on another important topic, which is the relationship between the resident, the preceptor, and the academic advisor. Can you all expand a little bit about how you manage that relationship and what type of communication was taking place? Whoever would like to go first.
I can go first. So my advisor is Colonel Bouvet, and Colonel Swafford actually would say, if you email him, make sure you just CC me on it, so I know if you're sending him a project, that we're all on the same page and he gets the feedback. I did a statistics project, so I emailed Colonel Bouvet just to look at it as well, other eyes on it. So probably once a month or once every other month, I would have contact with Colonel Bouvet to let him know I was still alive, still going to work and everything. So, but Colonel Swafford, I even think that they might have talked, just to make sure everything was tracking as well. I'm transparent to me, but it was a good working relationship, and I think that if there had been an issue, that we definitely could have, as a group, solved it pretty quickly.
I'd like to say that there was a couple of ways we communicated. Obviously, through email was probably the number one method, being at a remote site away from Army Baylor campus, of course. And so I acted pretty much as an intermediary between my preceptor and my advisor. So I don't know if there was, it was all behind the scenes and without, the man behind the curtain, but it was without my knowing. But primarily my preceptor would speak to me. I would run my bear by them. We'd do our quarterly reviews, and then I would then feed that back to my advisor with the requisite checkoffs and initials from the preceptor. And I did that, and then it kind of went both ways. So that was useful. Sometimes don't like being the middleman, but that's the way it was. Also, my academic advisor, we set up one day, and I went and I put it on my preceptor's schedule to meet with my academic advisor and Captain Downs. She came out for a site visit on location, probably about midterm. I want to say it was right after Christmas, maybe, of the residency, and we went there. We had lunch together and had a great conversation at that time. And of course, my preceptor had nothing but positive, great reviews about my performance to date. So it went really well.
Just one other additional comment is that I think the academic advisor, if you have questions about the methods or something about the residency manual, I think that's really the lane to go down. If it's the format of a paper, or and then also keeping them updated on your progress. And I always quarterly I checked in with Dr. Johnson, who is my academic advisor, and being in San Antonio was a unique opportunity because we're locally, and sometimes you run into them at a conference, or he would come over and teach where I was located. So, and then like same thing that James explained is that if my preceptor and my advisor were talking, I wasn't tied in on that, and so I'm not sure how much she reached out to my advisor directly.
So it sounds to me from what I'm hearing that a lot of the deliverables, when they came due, you ran it through your preceptor first and then through the academic advisor versus the other way around?
Right.
Yes.
Is that
Yes.
generally how things work?
That'd be great.
Great. And here's a I guess somewhat of a loaded question, since I know that some of your preceptors are here locally. But if you could do the residency year over again, what kinds of things would you change?
It's my turn. Okay, I'll go first, I guess. I would do two things, and I knew this question ahead of time. So the first thing I would do at a civilian-based residency, in the MHS we have access to M2. We know the system very well. I went through training on it. But over at the Texas Health Science Center, we had Epic systems, and I probably didn't have the access that I needed for a lot of my data. For one of my projects, I actually did a time study and collected my own sample just because I couldn't get access to the data that I needed for my project or report. So if you can help out your residents in any way, I'd recommend making sure they have the appropriate level of access. Probably one of the first things they do is go through your EHR training at your facility. And then the second thing is, and you can help your residents out with this, is that each quarter you can complete, I try to do about 2 projects per quarter. So 4 quarters, I try to have 7 or 8 projects, I'm not sure if they're changing it next year, but I tried to focus on 2 per quarter. And what happened was we knew so much about the referral system for our department. We became the subject matter experts, and everyone came to us about it. So after we finished the projects, we still had people coming to us that wanted information that was taking up time that prohibited us to work on the next project. So if you can help your resident out, I'd recommend don't let them dig themselves too deep into a project throughout the year. If your plan is that for them to have 4 projects and that's your guidance to them, then after they, let them be involved in other competencies, if I could recommend anything. So I try to get a diverse amount for my portfolio, but some residents were limited to 4 big projects. So help them out by just not letting them get too involved in a project, and then once people go to them, let them know that they've moved on to the next project, still helping out the organization if it's something immediate, but that'd be my 2 recommendations.
I'd say early on, make sure you kind of start working with your resident a little bit on the projects. What projects are you going to do? And of course, the resident is thinking, how am I possibly going to get enough projects that are going to be substantial and have enough data in them, and that I can, really show what my knowledge base and what we've actually done. So don't focus just on the projects. Make sure you throw in that best practice early on. That's what I would change. I kind of said, well, we'll find it, and I found one, and then sure enough, the data showed that it wasn't a best practice. So we had to, flush that one and start over. And again, we just don't have the data. There, like kind of what Jess alluded to, is as far as the data collection systems that maybe the military does have a nice representation of. I found in the civilian sector as well, it's not, the data you're looking for is not always there. And so I wasn't able to complete another best practice, and I ended up on a option C for my best practice, and it didn't really come together until much later in the residency. So I kind of had to sweat that one out a little bit. So don't forget about the best practice early on. That would be my recommendation, first thought of what I would do different.
I guess for me, I'm kind of the opposite of what Jess said, where he was talking about maybe diversifying. I felt we were so, we had a lot of diversification. We were like here one day and here another day and here another day and here another day. I didn't feel like, even when I was doing a project, like I was as intimately involved that I could really feel the pain. When I'm doing a project, I really wanted to so for one, I did one on the infusion clinic, and it's kind of a mess there, and they have an intimate relationship with the oncology pharmacy, and so neither one of those 2 places, I visited there, I talked to them, I pulled their data, I tried to do all of that stuff to see really what happened and what was wrong, what was going on there, but I didn't live their pain. I wasn't sitting in the infusion clinic. I didn't see why they didn't see enough patients fast enough and why so many were going out to purchase care, but I could sit there and make recommendations based on data, and to me, I wasn't getting the whole picture, and so I felt like I couldn't have as much impact. I didn't feel my recommendations were strong enough because I wasn't as intimately involved in certain departments. So I think for me, I would have rather have, say, been with the Department of Medicine for a quarter, and then in the Department of Medicine, I kind of went around and saw things, maybe got a project that way and stayed in that area and was able to like look and get my project that way. And then the next time I was in Department of Surgery next quarter, or maybe it's you can't do it that way, quite that way because of time that you need to get projects turned in, but something more like that where I was more like in depth and was able to feel the pain and be able to feel like I could make a better impact and my recommendation was stronger. I think that's it.
For me, I wish that in the beginning, I think this transformation that we have, you have to become a different type of leader. And so watching Colonel Swafford throughout the year, I actually said to him once, I was like, how do you sleep knowing all the stuff that's going on, you know? And so that, I think, I wish I would have understood a lot earlier how to be a senior level administrator. And he said, I know all of those problems that are going on, or at least I think I do. And I know that I have a good plan in place for all of them. And then I have to trust those people and I have to go back and check. And that concept, and then when we went out from then on, I always asked those leaders that he's talking about, what do you tell the DCA? What does he want from you? And if I was a DCA, what should I be asking of you? And it changed a lot of our residency, and it changed the way that I looked at what I was supposed to gain from this year. Because you go to inpatient records and you could go crazy because I'm like, you guys are 6 months behind. What are you doing? Everybody work harder. You know what's the problem? But that's not my job, is to go in and be an inpatient records tech. My job is to come up with them in unison with the people on the ground and come up with that plan and help them work that out, and then trust that that plan is going to be put into place. And in the beginning, I was really like that lower level leader still being like, well, I could fix all these places. Like, I have so many good ideas. But that's not my job. And I think if I would have understood that, maybe even like before the didactic year, that concept that he taught us very well, because he's very calm and could handle a lot of situations that were going on, it would have made the residency from a different perspective. And so I know that they said really good things, like actual concrete things, but maybe even just helping the residents really change the mindset of what they should be learning that year, and how to become like a high-level leader, not, on the ground fixing one particular problem. So.
Well, you all have provided some really great answers today. At this time, what I want to do is invite some of the audience members to come to the microphones to ask some additional questions.
These are the ones we're not prepared for.
Hello, students and future graduates.
That's right.
This year, during the residency, we implemented a couple of new initiatives in hopes of trying to make the residency a little easier for you and improve on it. One of which was incorporating the draft submission in January. Can you don't have to speak to it, so don't feel that we have to go all the way down the line, but can you talk to that a little bit, if it was effective, if that can be improved, any way that we can make that process better or even take it away? The second piece is even though you guys and gals weren't required to submit your portfolios in the new format, hopefully you all got a chance to see the new guidance and give a little input on that. And if you did submit one of your portfolios in that format, give us some feedback on how do you think we can improve that as well.
I can talk on behalf of the draft, or turning in a completed and draft. I think it was very helpful because it kind of, and I think maybe classes in the past had a hard time with deadlines, and so I know for us, at least for me personally, it helped me to stay on track. I knew I had to complete 2 projects it was my personal goal anyways, but then when it was made that goal, it was concrete, I knew I had to do it. And so it's kind of like a little bit off your shoulders. Hey, I've got 2 finished, and you still got 6 months left of residency before the whole thing is turned in. And so I think it really is a good thing to help keep people on track. I don't know about I didn't do the new format. I did look at it, and I didn't do it.
I'd agree with what she said about the usefulness of it, just having it be a priority and being a deadline that you have to meet. It certainly helped anytime you have that goal that you have to strive for. But I think both parts are kind of related to format. And for me, submitting the draft initially and then getting the feedback from my academic advisor was helpful in identifying what was the format essentially that maybe the faculty's looking for when I do my academic submission and portfolio. The second part was format also, and when it did come out, I think it was about halfway through the residency, and I was already too far gone, I think, into my existing format from the previous year, but I did borrow from it, and I took a few ideas, such as using just 5 of the competency on the cover sheet for each project, and focusing just on those 5 competencies for each write-up of the projects in the portfolio. So that was actually very useful. I think in retrospect, had I had that earlier on, I probably certainly would have embraced it and used that format to complete my project portfolio.
Some of the projects fit really nicely into the format, and some of them don't. So I don't know if there's different formats that you use for different types of projects. So, if you're doing, like, going to publish a statistics article, it's going to be much different than a process improvement project. So maybe if there was, like, 3 formats that you could choose from based on what type of project you're doing. Because I found myself, like, is this contextual factors? Is this background? That's really tough because it doesn't fit that format. And so I find myself trying to fit maybe something that doesn't really work. So it might be helpful to have multiple formats to choose from depending on what type of project you're doing.
Hey, how you doing?
So,
My question, I guess, what I want to pull from your guys' knowledge base is, right now our current students all year have been saying, I'm drinking from a fire hose. I was there 8 years ago, Colonel Peacock, Colonel Richter, a lot of us in this room felt that apprehension between didactic and residency going, did I actually learn something? What I'd like from you guys, for everybody here, is, one, what did your preceptors do for you to kind of ease that apprehension to say, you do know what you're talking about? Or 2, if there wasn't really an overt activity that they did for you, or what do you believe they could do for their residents to break through that barrier of apprehension that, yeah, you got this?
Guess I'll go first. That was a great analogy of it, of how you feel as a resident transitioning and going in. My first day was a senior working group meeting with all the physicians, and I just thought, how am I going to contribute to this team? And it was, but after you start getting involved with the organization, and your preceptor is supportive of you, so a good introduction right away so the staff, the executive staff, and even walking the resident around. You don't have to do it yourself, but have someone, assign someone to walk them around the organization so they understand who you are, and what you're there for to do. You're not there to, put a binder together and make copies. You're there to do executive level projects and to help the organization with some strategic decisions and use the education level that you have. But I would say, one is to make sure you have a good introduction in the student to the staff, and then offer the resident an opportunity to get up in front of that audience and speak. And I really think I felt more comfortable after I started doing projects for some of the clinics. I got to know people a little bit more after that first 60 days, and I felt more comfortable speaking and contributing during the executive meetings.
I think we're really lucky at BAMC, because I think when you walk around, there's like half of BAMC's graduated from Baylor, and so it's like everybody knows the new year's coming. There's new Baylor residents, and so I think just that alone, at least that there's already this amount of people have a respect. They know you're coming in. I guess the introduction. Right away, Colonel Swafford identified, hey, these are the meetings that I attend. and I expect you to be at some of them. He didn't say necessarily, like, I mean, I guess he said at least once and quarterly or something of that. We pretty much attended whenever we could, depending on our rotation, but being at those meetings and meeting people, like he said, I think that really does help. It gives you confidence. It helps you understand what's going on in the organization. We did drink through a fire hose, but I feel like, especially everybody in our class were amazing individuals, and I think that I'm confident that all of them are going to be great leaders here in the future. And so I think that the best thing the preceptor can do is just emphasize that, you guys are smart and great leaders. You wouldn't have been there in the first place. And I really feel like Colonel Swafford, always made us feel, he's amazingly smart. Sometimes when in the room with him, he would be talking to us, our mouth dropped because we'd be like, how do you know that? But at the same time... He never made us feel stupid or anything like that. He always, encouraged us and gave us and was complimentary to us, and that was a really great thing.
We also started the journey to being an HRO right when we got there, and he put us on the HR working group and had us read the books that they were reading and made sure that we knew the strategic goals and how it fit into where the commander was. So we felt smart on that, and we were able to talk and tailor some of our projects to make sure that we were working toward that goal. He also, I was just sitting in on a meeting and somebody said they had a problem. He's like, I got somebody here that can help you. So it kind of gave you that confidence, and that's how I got my first project. I was just sitting there at the right meeting, and so he kind of gave you that. He basically is endorsing you to finish that project and saying that he's going to back you. So that was important. Those two things helped.
I would reiterate just real quick, the introduction is really important. I think from the get-go, right away, my preceptor would introduce me and say, he's part of my A team. He's part of the C-suite. So, bring him into the boardroom. Let him hear the conversation, and so that they know that things start clicking that way. I think, pretty important. I think the introduction, of course.
Our last question.
Is it?
It is.
I have two questions. The first is you all are sort of familiar with this hotel, and it's along the lines of your familiarity there. So could you walk us through the 5 steps of the null hypothesis significance test? No, actually, in a few years, some of you will probably be sitting over on this side. And you've answered a lot of this question, I think, already, but I'm hoping that if I frame it a little differently, you'll bring out some more ideas. But you could be sitting over here in a few years. So what are maybe 1 or 2 things that you feel that you would do the first thing you do when you find out you're getting a new resident to help make them successful? What are some things, either initially or along the way? You can go back to the first question if that's...
So what do you all feel that you would have done differently? Or not only what you would have done differently, but what advice do you have for our incoming preceptors?
I think we've given... Oh, I'm sorry.
No, you're good.
Go ahead. Okay. I think we've given the impression that we were talking to our preceptor all the time, but we've talked before we started that we had a lot of autonomy. We met every other week, and sometimes, unless we were in a meeting, we didn't really have any conversations. He really let us go be those leaders of the project, or and even sometimes we'd come with an issue and he wouldn't come up with the answer for us. It was like, I really was hoping I'd come out of there with the answer to that question. And so he gave us a lot more autonomy than I was expecting. He really let us go out there, and we were representing him, with our work. So I think that's a big... I don't want you to think that we were like next to him the whole time. I shadowed him one day, but for the most part, he expected us to go out there and get the work done and come back and let him know what we did at that 2-week meeting or in our weekly report. So autonomy was, I guess, something that we didn't answer before.
James?
Right. I was going to say that know that when your resident comes to your facility, they're coming with a lot of enthusiasm. They just, they just won the lottery. They passed their oral boards, right? So they are so happy about being at their residency site. They want to go and do good things. So let them. Be careful. I would advise you of line of sight tasking. I know it's kind of a term we've used in the Navy for a while. We're trying to get away from that. But when you have a little project, I know like for example, one day the chief nursing officer's executive assistant was out of office, and she needed a Gantt chart. So it's okay to test your resident. Say, can you go make me a Gantt chart? Yes, absolutely. But we certainly have those skills. But know that we want purpose and meaning in our projects also. So please, don't underestimate us. It's okay to test us, but make sure it opens up to new things. And yes, that Gantt chart led to a fully developed project that I became a project manager on, and ultimately we got a national recognition for the hospital, a certification. So it really, it can be great things, but just be careful of line of sight tasking and the level of a project that you're giving your residents. Thanks.
I think one thing, I don't know if this could have to do with the preceptor, but I know as far as an experience is concerned, and maybe this goes more to the residency, the people who determine who's doing the residencies, is like, I know like James, he was by himself, but there was 3 of us at BAMC, and I think that made our experience better, because we were able to do we didn't collaborate on any projects, but we were there for each other all the time. We did rotations together. We were able to bounce ideas off each other all the time. So I think we made our learning better. If we were somewhere, Eileen loves to ask questions, and she always say, "Did I talk too much?" And we're like, "No, you didn't talk too much." But she would ask things that I didn't think about asking, or she would say something that made me think of something else. So I think it really enhanced our learning, enhanced our rotation, and that was a really good thing. Being at BAMC, we have like a business operations division, we have data analysts, we have every analyst you can think of, and so we weren't really ever that often ever tasked to do mundane things of that sort. So we at least didn't have to. I've heard a lot of people say that they've had to do that during their residency, and I don't think that was really our experience at all. I do think one thing that our preceptor did too was he never said, hey, he constantly bombarded us with, hey, this is a project idea. Because, again, we have a lot of Baylor people there, and so people are saying, hey, we have this issue. This might be a Baylor resident, job, ... And so he would forward them to us. But he also gave us that autonomy to decide that, are you interested in this? Is this going to fix a competency you want to meet? And I appreciated that about him. He never said, you're going to work on this project for us. He gave us that opportunity to decide based on our own interests and needs.
I think that's a good comment for the faculty as well when they're looking at sending people out. BAMC, being an academic training institution, people you do your rotations with already kind of understand what this is all about. And, I don't know if that's always the case with all of our institutions. At Fort Carson, sometimes it takes a little bit more direction when we send them out because, they're just not as familiar.
Okay. Well, on behalf of not only the faculty, but our audience members, we want to thank our new future healthcare leaders for providing their insight this afternoon. So thank you very much.
Congratulations to you all.
Thank you, sir.
Really quick before our next guest, our next speaker comes up to the podium, I do want to provide some administrative announcements. In the back on the table, right before you leave, there will be a survey. I would really love for you all to fill it out. And in fact, as an incentive to ensure that we receive them back, we will be providing you with a small token of our appreciation if you turn in a survey. So if you can think about all the sessions that you saw today and were a part of, and if you could please provide feedback, we really do want to use that so that next year we can make this even better. So with that, Forrest.
So I